Hello. Hi, Sudhir. Is that Manasi?
Hello. Hello. Yes. Good evening, sir.
Good evening, Manasi.
Yes, sir. You want to share your presentation and check once?
I don't have a presentation. No, the resident is going to present, right?
Sorry.
Um, the JJ resident is presenting, right?
Uh, I am not quite sure, sir. I have been told that you are the expert, so I assume that you are the one who's going to be presenting.
I was told that the format is that we have to run it like a clinic, and the JJ resident will be presenting. So I have the presentation, but if you want, I can just cross check.
Okay, sir, just give
You
me a
must have
moment.
done this before, na?
Uh, we have done this before, but usually the other people log in. Nobody else has logged in, so except for you. And Dr. Rakesh Singh will be joining us within few minutes.
No, so it is not a didactic lecture. There are four of panelists who are the students,
Yes, but
and they
it
will be
is
discussants when we ask questions. And the JJ resident, I think his name is Abhay. One second.
okay. Okay, so okay, just give.
So long case presentation. The resident's name is. Hang on for a second. I was given to understand that he will be yes. So his name is
Dr. Devashish.
no no. No, Devashish is not presenting. This is
Presenter. Presenter. I thought.
Abhay Bagul. This
No,
is
sir.
Abhay Bagul. And I was told that Abhay Bagul is going to present the case.
So at least I am not aware of this. I'm sorry. I'll.
I had asked him the question, who will present the case? You? This is yesterday at 10 o'clock at night, and he said, yes, sir, at 10:07.
Yes,
So
sir.
then I said, then I should be quizzing the other students. He said, mostly 3, 4 residents will be there as panelists. I assume they do not know the case, I said. So he said, yes, sir, you can ask me also. So I know for sure that he's presenting the case.
Okay, so then let's see. Let Dr. Rakesh Singh log in. Then we'll see.
So it looks like I'm the only idiot who's on time. Maybe a little before time. 2 minutes.
No, so usually everybody logs in at 8:15.
I do have, he has sent me the presentation yesterday, but it says clearly case presentation by Abhay Bagul.
Hmm.
So I don't think I'm presenting the case. What do you do on other Thursdays?
So there is one person who logs in, one expert,
Ah, okay.
and then
No, I
they are
think
the ones who present. They are the ones who present.
so. This conversation is very real, no? I am doing this for the first time. So I received the PPT yesterday at night. So
Okay.
I asked him, who will present the case, comma, you? He says, yes, sir.
Okay.
So I said, then I should be quizzing the other students. He says, and mostly 3 to 4 residents will be there as panelists. I said, I
Okay.
assume they do not know the case. He said,
Okay.
yes, sir, you can ask me also. I'm quoting verbatim from my WhatsApp chat.
Okay, sir. I'll just open the room. Then we'll have all the other people also logging in.
I thought this was a set format.
No, this is actually a new format.
Well, so
We have Dr. Rakesh Singh coming in.
yeah.
We have Dr. Devashish Ruikar also coming in.
So I cannot see anybody.
Yeah, they will just log in just in a minute, sir. Yes, we have Dr. Rakesh Singh and Dr. Devashish Ruikar in already.
Right? Very good.
Let me see if we can also have Khalkar sir in.
Adilkar sir should be also coming in. I believe he said he will
Yes,
be
yes.
there.
Yes, he will be there. Yes, in a minute he'll be there.
It is not the fine morning. This is late evening. Yes, Adilkar sir has come. He's there.
Yes.
Yeah, Khadilkar sir already there.
Good evening, Joy sir.
Yeah, hi, good evening. Hi guys, everybody. I'm very much here.
Hi, very good
I,
evening, sir.
good
Hi,
evening.
alright.
Yeah,
I,
sir is joined. Sir is
Good
I
evening,
think
sir.
Mansi was telling me that I'm supposed to present the case, so I got a little taken aback.
joined.
Abhay is presenting the case, right?
Yeah, Abhay will be presenting. Yes.
Yes. No, I understand that. That's what I told Mansi.
Yeah.
So should we because
I mean, students have not joined, yeah, Mansi?
Yeah, around 80 students have joined,
so
sir.
can you tell
No,
me the
four
name of,
panelists.
The
Panelists.
panelists haven't joined in apparently.
so can you tell me who the panelists are, please?
Abhay is there.
His full name Dr.
Abhay Bagul.
Yeah,
Abhay,
he's there. I'll move him to the panel.
then
All the other students who are
Riddhi.
Can they raise their hands?
yes, that is what I was going to say. The students, I'd request them who are supposed to be in the panel, please raise your hand so that
I
we can
think
move.
Karthik is also supposed to be in the panel.
Riddhi. Riddhi Patel is there.
So, Doctor, there is one anonymous person who has raised their hand. Let's see if
Must be Rohit. Rohit from Bangalore.
Good evening, sir.
Abhay.
Hi, Abhay. Abhay is here. Hi, Abhay.
Good evening, sir.
Good evening.
एक रोहित होगा. I'll just tell him to raise the hand.
Or they can send a message in the chat.
the chat, yes. There is someone who has logged in with the name Great P. I would request you to please.
I cannot change the name. I had tried it.
So
But
Karthik was also supposed to join.
So Dr. Karthik has joined. So
I am
Dr.
here,
Karthik
sir.
has.
Karthik, are you there?
Yes, sir, I'm here. Hello.
Yeah, very good. So Karthik's in.
Okay, Great P. If you can tell me your name, I'll rename you.
Riddhi Patel.
Yeah, so Riddhi is here. So I think somebody, Rakesh was mentioning.
Rohit is yet to join. I am just calling him.
Who is there? Karthik is there, Abhay is there.
So we have
Riddhi.
Karthik, Dr. Abhay, Dr. Riddhi.
So Mansi, what I'll do is I'll keep my video off so that there is
Okay.
no bandwidth infringement.
Shall we start? It's 8:35.
Can I share my
We're
screen?
waiting for only one.
Sir, I'll just call him. So he will raise his hand.
Okay.
Great.
I think we can start. He can join.
Yeah, we can start. I'm keeping my video muted, so you can hear me. That's fine. There's no point everybody
There are
infringing on the bandwidth available.
120 participants, so I think we can start.
Yeah, I'm all set.
Great.
Good.
So, good evening, everyone, and let me welcome all of you to this Thursday tutorials. Today, we're going to cover an important subject, the spinal cord, and we have Dr. Joy Desai with us. As you know, Dr. Joy Desai is a very good clinical neurologist. He's very extremely well read, as you will find in the course of the evening. He's currently the director of neurosciences at the Jaslow Hospital, and he has multiple special interests. I recently came to know that painting is one of them. So, Joy, welcome to this Thursday.
Thank you, Satish, for the very kind introduction.
There are a lot of students here from various parts, and they actually participate. And we've got four
Mansi,
panelists today. We've got Abhay.
Yes,
Mansi.
Rohit will raise his hand. He has
yes,
joined.
he has. Yes, I have moved him in, sir.
Sure.
So we have got Abhay Bagul from the Grant Medical College who will present the case. Then in the participant, there is Karthik. There is
He's from Jaslow.
Riddhi. And Karthik is from Jaslow. Riddhi is from Bombay Hospital. And who's the fourth? Rohit from which hospital in Bangalore?
St. John's, Bangalore.
Super.
Rohit, which hospital?
Sir, I'm from
St.
St.
John's
John's Hospital,
Very nice.
Bangalore, sir.
Super. Very good.
Very nice. Good. Welcome.
Thank you, sir.
Great. So I hand over to Abhay and Dr. Joy Desai.
Right. So, hi, Abhay.
Thank you, sir. Good evening.
Good evening. So I think when we do bedside clinics, the fun is in interacting with the person who's presenting the case, which is going to be you, and the other students. And I believe we have three others in the panel. There's Riddhi, there's Karthik, and there's the gentleman from St. John's. So you can present the case and we can discuss as we go along those things which strike our neurology excitement based on what you tell us. So proceed.
Okay, sir. So my patient is a 29 years female. She's a right-handed farmer by occupation. She admitted with the complaints of headache with neck pain from last 3 months. Change in speech and difficulty in swallowing from last 2.5 months. Imbalance while walking from last 2.5 months. There is a weakness in left upper limb and decreased sensations on the left side of face, left side of body, right trunk, and right upper limb from last 2.5 months.
Right. Great. So Karthik, are you there?
Yes, sir. Hello.
Yeah, Karthik. Karthik, yeah, there you are. So Karthik, Abhay tells us that here's this young person. She has presented with nuchal pain, an alteration in speech, dysphagia, some imbalance while walking, and somatic symptoms in the upper limb, and some very graphic sensory dysfunction involving the face and the hemicorporeal um, parts of the trunk and limbs. So based on these first four things that you have been told, what would you think is the way we should be analyzing the lesion localization for this lady?
Sir, he has a headache and neck pain since last 3 months. So
Right.
it may be because of the meningeal involvement.
Mm-hmm.
He has change in speech and difficulty in swallowing from last 2.5 months. So, and also imbalance in vocal. So it could be due to involvement of the cerebellum or associated with the lower brainstem part because he has difficulty in the swallowing. And he also has weakness in the left upper limb, decreased sensation in the left side of the face.
So you have that information. So what do you make of that?
So maybe kind of dissociative sensory loss
Mm-hmm.
could be.
Okay, so
So
you're saying
maybe
this is dissociative sensory loss
because he
in
has
the
decreased sensation on the
soma, but he's also saying that there is some dysfunction in the left side of the face.
yeah. So maybe because of the involvement fifth now.
All right.
Yeah.
Okay,
And
so you're thinking that there is some dysfunction in the cerebellum, maybe, and the pain arises from space occupation, you think?
he has also long trunk signs.
Yeah, we have not come to signs yet. These are only symptoms.
Yes, sir.
So, is there any specific question you want to ask Abhay before he proceeds to the next slide?
No, sir.
Wouldn't you want to know whether she's vomiting?
Yes, sir.
Listen,
To
so
space
Karthik,
yes, sir. To localize the space occupying lesion.
right. No, the question is, Karthik, you told me a few minutes ago that here's a constellation of symptoms with which the patient has come to the neurologist, that is you, and says that, doc, these are my symptoms. So you're trying to think that, okay, if these are the symptoms, then I'm localizing my lesion to maybe cerebellum, maybe bits of the brainstem, as you yourself said, to
Yes.
explain the dysphagia, and maybe speech, but that could be a question mark. But distinctly, you said that you think there is some dysfunction in her trigeminal functioning in the brainstem. So you have some clear pontine dysfunction too, right?
Yes.
And then there is the corporeal hemisensory dysfunction. So you did, wouldn't you want to know whether there is any history of vomiting, because that would tell you
Yes, sir.
this kind
Specific
of
by
change in the posterior fossa with an involvement maybe of the craniovertebral junction, whether there is
yes,
raised intracranial pressure, right?
yes,
So Abhay will proceed. Next slide.
So patient was apparently all right 3 months back. Then she developed a headache, which is more on the left side, posteriorly. It was dull aching, continuous, and with a mild to moderate severity. And the headache increases by coughing and straining. Otherwise, it is not associated with omitting any visual problems or autonomic features. There is also neck pain with headache from last 3 months. Again, it is more on the left side, dull aching. It is continuous and mild to moderate severity, and it is non-radiating to any dermatome.
Right. So Abhay, did she say that she had pain also on laughing?
Yes, sir. With coughing, pain increases, sir.
And she said laughing too?
So not specific. I have not asked for that specific.
Right. Okay, Karthik, you want to ask him do you need any more information, Karthik?
any history of sleep related any breathing disorder? Because
No, there is no history of breathing disorder or sleep abnormality.
okay,
So why are we thinking about a sleep-related breathing disorder?
because in the craniovertebral junction, patient can have the central apnea.
Because your concern is that if there are some symptoms which are related to brainstem dysfunction, you're worried whether these brainstem symptomatology have also encompassed and involved um, the respiratory centers, and you're not sure about that, right?
Yes.
Right. So far we don't have symptoms to say that.
Yes, sir.
Okay. He's told you very clearly that this patient has complained of headaches which are increased by coughing, straining, and he didn't ask about laughing, but I would have asked about laughter. That's an important symptom. So, Karthik, what is the relevance of that? Why does someone who has headache or coughing and straining imply a particular pathophysiologic process? Would you be able to analyze that and tell us what you think? It's open to the other two also, Riddhi and is that Rakesh? Is the other person?
Rohit.
Rohit,
Dr.
is-
Rohit, right? Rohit, sorry. So Rohit and Riddhi, to any three of you, any of the three.
Sir, headache is increased on coughing and straining, and
Right.
also left side, and also it is continuous
Right.
with mild to moderate severe. It is suggestive of raised intracranial pressure, sir. Raised intracranial pressure, however, not associated with vomitings. And together with all the symptoms, since 3 months, which is progressive, and then there is involvement of raised ICP and also involvement of the pons, medulla. So I would like to put it as a progressive brainstem disease with progressive brainstem disease, probably secondary to the infections, bar posterior fossa tumors, bar um, inflammatory, any other inflammatory conditions.
Right. So
Sir,
we
during
were
the
in these two slides we were discussing that here's a patient who clearly has headache. Now, when we know that the structures in the neuraxis that induce headache are either the dura and the coverings of the dura, if there is some dysfunction, inflammation, straining, traction, or raised traction due to raised pressure, for example, in the
Yes.
dura, that it will give you headaches, and the other headache-inducing structures in the neuraxis are the vasculature. So
Yes.
if you take these two things aside, most of the other contents of the neuraxis do not induce pain, right?
Yes.
So when we say that there is headache but there is no vomiting, yet there is an induction of the headache by coughing and straining, is there some derivation you can make out of that, or you think it's not it's something that we should
basic
let it pass?
Sir, any foramen magnum pathology will give rise to the increase that craniovertebral anomalies or the craniovertebral diseases will give rise to this type of symptoms due to the increased ICP due to Valsalva maneuver. So the venous stasis will be there and it will give rise to this type of symptoms while cuffing and straining. The pain will be aggravated.
Right. So the one way of looking at this, you're right, I agree with what you're saying, but perhaps one way of putting it would be that there is some evidence that the intracranial pressure mechanisms have got altered. And whenever there is a subtle rise in intracranial pressure, which you and I tolerate very well, and we will not, because we don't have a pathology in our neuraxis, in this patient, it induces headache. Yet it is not severe enough to induce vomiting, either spontaneous, projectile, or otherwise. So we've all been taught about projectile vomiting, but we know that that's one end of the spectrum. A person who has really very large increase in intracranial pressure can then have unremitting headaches and maybe spontaneously vomiting, and that vomiting may be projectile because it comes on suddenly with sudden rises, intermittent sudden rises in intracranial pressure. Here, the pathophysiological process seems to imply that whatever has changed the dynamics of intracranial pressure is indolent and it's slow. When it is added to by the process of doing a Valsalva like coughing, straining, or laughing, prolonged laughter. We didn't ask, but I assume if this patient was sitting in front of us and we asked about laughter, it would have come through. So it's the difference in the severity of the pressure rise that gives you this constellation of symptoms. Great. So proceed. Next slide.
Yes, sir. From last 2.5 months, she also developed nasal intonation in speech, and speech is loud intermittently with frequent pauses, although her speech was intelligible. There is also difficulty in swallowing. It is for both solids as well as liquids. And there was history of nasal regurgitation of liquid and food. And she would cough while drinking and eating. Otherwise, no history of inappropriate laughing or crying.
So Karthik, what do you make of this now? There is nasal intonation, there is regurgitation of liquids and food from the nose while swallowing, and Abhay very clearly mentioned this distinctive symptom that the speech is intermittently loud with frequent pauses. What do you make of that?
It's maybe because involvement of the lower brain stem, on 9th and 10th cranial now, because yes, difficulty in for swallowing
So
liquid
if a
and
patient has nasal regurgitation of swallowed food and liquids and has a nasal twang while speaking, which is a de novo new twang, which the patient did not have earlier, where do you think in the anatomy is the problem? What do you think is not working?
palatal
Why?
weakness.
Palatal weakness, right? So the palate is supposed to close the nasopharynx when we are swallowing. That palate is dysfunctional, and the closed palate also makes sure that the voice has a broad baritone to it. If it becomes nasal, that means there is some escape of the air while intoning syllables and words, and that's what gives a nasal twang. So there is a dysfunction in the palate. So we are going to examine that when he comes to the examination and find out, is the palate really weak? Is it unilateral? Is it bilateral? He also said something about speech being intermittently loud with frequent pauses. He's saying that with a valid reason. What do you think he's trying to tell us from that symptom? Karthik?
Uh,
In terms of neurological understanding of the regulation
it
of
could be
speech.
it's involvement of the cerebellum.
Right. So what does this mean? What is this intermittently loud with frequent pauses mean?
Scanning type of the speech.
This is staccato speech, right? He's trying to tell you that this is a verbal translation of what we would call staccato speech, right? What is staccato speech? Staccato is something that comes in bursts, right? And it's coming in bursts, which is intermittently loud, and there are frequent pauses. He did not tell us that these pauses were variable, but if he had told us that these pauses were variable, it would define very clearly staccato speech. Yes, if someone has staccato speech, you would worry about the cerebellar regulation of the laryngeal motor system, right?
Sorry, sir. Sir, Joy, sir.
Yeah.
Sir, your voice sometimes breaks. Probably you have to come little nearer to the mic.
Yeah, so all right, am
Yeah,
I
yeah. Now
better
it's
audible
better.
now?
Yeah, yeah. Much better. Much better.
Right. Thank you. Sorry, this my earphones were hanging, so
No
I
problem.
lost that. Okay. So he's also saying there is no inappropriate laughing and crying. Why do you think he asked that? Anybody? Why do you think he's asking about inappropriate laughter or crying?
To rule out
pseudobulbar involvement.
Right. So that's a symptom of pseudobulbar dysfunction. And in this story we have heard so far, is there anything that tells us that the dysphagia is pseudobulbar?
No, sir.
No.
Not really, right?
No.
But this is a useful thing to know. Okay, Abhay, you can proceed.
Yes, sir. From last 2.5 months, there is also imbalance while walking with, and the patient sways on both sides, also front and back while walking. And other people say that she walks like a drunken person, but
Right.
still she managed to walk without support.
Okay.
And there is no history of unprovoked fall. There is no history of imbalance while washing face or increase in imbalance in dark. And there is no history of vertigo.
Right. So Riddhi, you want to analyze this?
Yes.
We've got a new set of information, and this information is going to paint a little picture about where in the nervous system are the problems and which parts of the nervous system are probably not affected. So what do you make of this slide? How would you analyze what you've been told in this slide?
Yes. Sir, imbalance while walking, swaying on the either side. So it will localize to cerebellar or its connections.
Right.
And there is no history of unprovoked falls and imbalance while walking. So probably the sensory part, the posterior column and the that is not involved. So and no history of vertigo also. So vestibular part is also not involved. So maybe it's more likely due to the cerebellar or its connection, sir.
So you're saying that we have information from Abhay, which seems to imply that there is some clear, unequivocal dysfunction in the cerebellum or its regulatory connections to other parts of the immediate vicinity of the brainstem. It's about this unprovoked fall that he said. It's fairly intriguing when somebody says that it should be intriguing to the neurologist when somebody says that there is no history of an unprovoked fall. So Karthik, when a patient comes and tells us that, or a caregiver tells us that this individual who's suffering from the neurological ailment is falling in an unprovoked manner, how do you try to analyze the neuraxis that regulates postural reflex control?
Probably he is having truncal ataxia.
Right.
Yeah, so could be because of the involvement of the vermis of the
So in which condition have you commonly seen in your experience? In which neurological condition? No, what I'm asking you, Karthik, in which clinical conditions in the clinic do you hear very commonly a patient give a story of frequent and unprovoked falls? What's the commonest thing that we see in our clinics?
Parkinsonism.
Parkinsonism. What kind of Parkinsonism?
Atypical Parkinsonism, particularly.
Which kind of atypical Parkinsonian patients?
Progressive supranuclear palsy.
Right. And what else?
And also could be multi-system atrophy.
All right. So you're saying that atypical Parkinsonian syndromes like PSP or multiple system atrophy often present with early falls and frequent falls in conjunction with their symptoms of Parkinsonism. That is a slowing of movements with or without tremor and change in their speech. Right? So here somebody is telling us that there is no history of unprovoked falls. So can you surmise anything from that? That so far, what parts of the neuraxis would you exclude as being an important area in the dysfunctional pathology that she has.
Extrapyramidal can.
Right. So far, it seems that maybe the extrapyramidal system is not involved. We have enough evidence from his story to say that the cerebellum and these connections are dysfunctional. He's told us that there is no vestibular dysfunction, there is no true vertigo, and he's told us that there is no imbalance while taking away visual input like washing the face or in the dark. And that tells you that perhaps the posterior columns at this moment don't seem to be affected by the primary pathology that she's dealing with. Okay, Abhay, that's good.
Yes, sir. And from last 2 months, she noticed weakness in the left upper limbs as she was not able to lift the heavy objects with left upper limb due to the poor hand grip, and also not able to twist clothes while washing. Also,
Right.
she noticed difficulty in buttoning and unbuttoning with the left hand. However, there is no history of difficulty in combing the hairs, and right upper limb is normal. And also, she could get up from squatting position, and there is no history of slippage of chappals.
Super, that's a fantastic slide. So, Karthik, you have to tell us that this is a very succinct set of symptoms. He's told you, Abhay has told you that she has left upper limb weakness, that she's not able to lift heavy objects, yet she can comb her hair, and her grip is poor, she's not able to twist clothes while washing, she has difficulty in buttoning and unbuttoning of the left hand. So, what's Abhay trying to tell us?
So it could be due to he had distal hand weakness.
Right.
Yeah, and then he has no.
So, what are the symptoms that he told us that reflect distal hand weakness?
Because his grip is poor.
Right.
And
So,
yeah,
buttoning, unbuttoning, and twisting clothes while washing, that is predominantly distal, right?
yes.
And what about the proximal muscle? What did he tell us?
Because he has no history of difficulty in combing hair,
But
and she could get up from the squatting position. So
but
But twisting of clothes is not possible. So maybe the biceps or the brachioradialis is involved.
no, look at the big picture. Look at the whole picture. What he's saying is that there is no difficulty combing hair. There is no difficulty getting up from a squat. However, lifting a heavy object above the shoulder, that's what he's trying to imply, is weak. So there may be mild weakness in the proximal musculature of the left limb, but so far the proximal musculature in the right upper limb and the lower limbs is not affected.
Yes.
In fact, he's very clearly also told us that the distal musculature of the lower limbs are also perhaps not symptomatic as yet. He's told us clearly that there is no slippage of footwear during ambulation. So that perhaps tells you that with all this constellation of symptoms, at least in the lower limbs, proximal and distal muscles not affected. In the left upper limb, maybe a little bit of mild proximal weakness because of inability to lift heavy objects. Remember, she's a farmer, so she must be using heavy objects in her day-to-day work. So it's predominantly distal, but maybe a mild proximal weakness in the left upper limb. Okay?
Yes.
Right, good.
And from last 2 months, she also noticed decreased sensation on the left side of face and more on the lateral aspect of face, then left side of body, both upper limb and lower limb, then right upper limb and right trunk. And she was not able to recognize the hot water in those areas while bathing. However, she could feel touch of the cloth in the same areas.
Right.
There is no history of difficulty in chewing. And she also complains of spontaneous, deep, painful pricking sensations on the left side of body and right upper limb. And there is no history of ulcers in the limbs.
Okay, Karthik. So we have some new information. What do you make of this?
Hello.
Yeah, Karthik.
Yeah. So she had decreased sensation on the left side of the face on the lateral aspect.
You've got the information, so you need to analyze it. Don't repeat what he said.
Yes, sir. So it's could be involvement of the spinothalamic tract because she was not able to recognize the hot water. So, and she could feel the touch of the clothes. So could be involvement of the spinothalamic tract. And yes, she also had decreased the left-sided face on the lateral aspect. So could be involvement of the spinal tract of the fifth nerve.
Good. So he's clearly telling you that there is a predominantly asymmetric involvement of the trigeminal sensory nucleus, and in conjunction with that, perhaps there is an involvement of the spinal tract of the trigeminal nerve, producing these constellation of symptoms, and it is not affecting so far large fiber sensation. So we analyze that better once we have more information on his examination. Okay, good. Proceed.
Yes. There is no history of fever, trauma, seizures, or altered sensorium. There is no history of cognitive decline or language disturbances, no history of ptosis diplopia, no history of facial asymmetry or difficulty in hearing. There is no history of bowel bladder disturbances, no history of breathing difficulty or sleep disturbances. There is no history of blackouts on standing or abnormal sweating. Past history is normal. Personal history, there is no additions and no comorbidity. And family history is not significant.
Right. So Karthik, he's answered your question about breathing and sleep disturbances. He's also said no blackouts on standing or abdominal sweating, implying that in general there is no widespread dysautonomia that this patient is experiencing, right? Because of the predominant dyslexia. He also told you that there is no difficulty in chewing, which means that though the trigeminal nerve is asymmetrically involved in the pathological process that this lady is suffering from, it seems to have spared so far the motor fibers of the trigeminal nerve, and therefore she has no difficulty in chewing. So now that the history is over, Karthik, you want to summarize where the localization is? He's going to localize, I think, in the next slide. Is that right, Abhay? The next slide is localization?
The summary. So,
Right.
summary is a 29-year female with 3-month history of subacute onset and progressive continuous headache with neck pain, with left fifth sensory and 9/10 cranial nerve paresis, and more likely of the nuclear type, with cerebellar involvement, with left upper limb weakness, and it is likely to be semidistal and distal, with left-sided and right upper limb and trunk dissociated sensory loss, because the temperature is affected, but the fine touch was normal.
Right.
And also there is continuous pain, so dysesthesias were there, and specifically there is no bowel bladder involvement.
Good. So Riddhi, you want to have a go at what you think is the lesion localization for that entire gamut of symptoms with which she has come to the neurology clinic?
So, young female started with the headache and relatively asymmetrical involvement and with lower cranial nerves, with cerebellum and upper limb involvement also. So I would like to localize, sir, most likely extraaxial with both can be the possibility. Intraaxial with extraaxial with intraaxial lesion will be the my first differential, and after that the extraaxial lesion involving the posterior fossa.
I'm not so sure that everybody has. I understand what you mean, but you could have made it a little more comprehensive. Karthik, what do you think? Karthik, you around? Karthik?
Hello.
Yeah, can you hear me?
So it could be involvement of the lower brainstem and plus cerebellum, and because she had dissociative sensory loss, so it could be some intramedullary lesion also.
Right, and you are presuming intramedullary lesion of some kind on the basis of dissociated anesthesia?
Sure.
Dissociated sensory dysfunction, is that what you're saying?
Yes, sir.
Okay, well, that's a thought. But clearly, this lady also has asymmetric limb weakness. So we will have to find an explanation for that too. Right?
Yes.
So what is apparent is that the parts of the neuraxis that are dysfunctional from her symptoms so far have a fairly large extent in the rostrocaudal direction. We are talking about someone who has fifth nerve dysfunction, someone whose cerebellum is dysfunctional, someone whose ninth and tenth nerves perhaps are dysfunctional, and someone who also has limb weakness. So that's a large part of the neuraxis, with some parts in between that are spared. So that's striking, isn't it?
Yes.
So this is a very unusual constellation of symptoms per se, because it implies that whatever is the dysfunction is structurally not homogeneous. Some parts of the neuraxis are preferentially dysfunctional and manifest in their presenting symptoms, whereas other parts may be affected, but we don't know that yet because we haven't examined the patient. So would you be able to hazard any kind of um, guess or a hunch as to what you think we're dealing with?
Could be CV junction anomaly,
Mm-hmm.
uh, like Arnold Cherry malformation.
Okay. You have a differential diagnosis, so one,
So she is a farmer also. So
right?
maybe unnoticed atlantoaxial dislocation
Yes.
or the any infectious causes, but fever is not there. So that is odd part.
No issue of
So,
trauma also is not there.
yes.
Right. So Riddhi, have you seen patients with atlantoaxial dislocation?
So they used to present with usually with the quadriparesis and
So there's a saying that if you have an atlantoaxial dislocation, the very apt description of what the patient has is numb hands and weak feet. Right? So they have weakness in their lower limbs and they have sensory symptoms in their upper limbs. And these can be triggered by a very rapid flexion extension movement. For example, if somebody knocks them from on their occiput without their knowledge from behind, or somebody is trying to jump through a hoop and you land on your feet, then that can produce a minor whiplash. That can suddenly trigger symptoms. So here, what is striking is that the dominant symptom is headache, and she clearly mentions nuchal pain along with occipital pain, and with the headache is a bunch of neuraxial dysfunction. There's trigeminal sensory dysfunction. There's probably palatal dysfunction. There's cerebellar dysfunction. There's ataxia. There's slurring of speech. There is staccato speech as being described by Abhay. So it would be very unusual for cerebellar signs to appear in atlantoaxial dislocation, isn't it?
yes, sir.
Right. So I wouldn't worry about atlantoaxial here. What else could be the differential? I agree that most of you think this is a craniovertebral junctional anomaly. You are aware of the spectrum of craniovertebral junction anomalies. So you know of other craniovertebral junctional anomalies which can form a part of the differential when you see patients with these symptoms.
One possibility is neurosarcoidosis or Sjogren's syndrome, sir.
Okay, and why do you say that? That's a thought.
Multiple yes, sir. Multiple cranial neuropathies are there, along with involvement of pyramid tracts and also spinothalamic tracts, uh, and also progressive. So we can think of differentials like neurosarcoidosis and Sjogren's also.
That's very good. I think you're trying to say that yes, we know that there are segmental parts of the neuraxis that are affected, and however, our derivation that this is necessarily compressive in its pathology may not be correct. It's an alternative possibility could be that this may be a non-compressive intrinsic pathology affecting these parts of the axis, and we know that if there is a predominant trigeminal sensory dysfunction, then amongst the inflammatory conditions, sarcoid and Sjogren syndrome figure as an important key differential, producing inflammatory trigeminal sensory dysfunction. I would kind of agree there. I would still find it difficult to explain the upper limb weakness and the very odd asymmetric weakness she has, distal specific. When you say, when someone can't unbutton their clothes, or when someone can't twist the clothes while washing them and squeezing the water from a wet piece of cloth, it tells you that the lower cervical, C
8 and
6,
T1.
7, 8, and T1 are affected. Those muscles are affected because we know that the innervation of the distal musculature of the hands.
Sir.
So while sarcoid and Sjogren is a good thought, my concern about sarcoid and Sjogren would be that A, this is very, very segmental and asymmetric, and I would find it difficult to explain sarcoidotic distal unilateral limb weakness.
Sir, one more possibility is it may be a false localizing sign also because of the venous stasis and leading to the damage of the fibers of C8 and T1. So that's why we are seeing distal muscle involvement also in this case.
All right, that's a thought.
But that is more
Basilar
only, sir.
basilar invagination, sir.
Right. So that's what I was waiting for you all to tell me, that one of the other things to worry about in this whole spectrum of craniovertebral junction anomalies is that there are two dominant kinds. The one where is Arnold-Chiari, which can often present with something like this, and the other is basilar invagination. So do you think that basilar invagination presents slightly differently from Arnold-Chiari? Have you seen someone with basilar invagination? What do you know of how they present it? Karthik,
Basilar,
reading?
sir, basilar is invagination can be associated with the Chiari malformation.
Yeah.
So can have the sensory type of sensory dissociated sensory loss, and mostly it used to be on the anterior part. So the odontoid process compresses the lower medulla. So the compressive symptoms could be explained by the it's not a cruciate paralysis, but the upper limb weakness could be due to lower medulla involvement. The upper limb fibers used to cross at the lower part of the medulla. So that is caudal.
Yeah, so one way of looking at this, I understand what you're trying to say. Perhaps one could think about that. But if you see the pathology of basilar invagination, it is an anomaly that is likely to produce symptoms rostral to its abnormality. Whereas Arnold-Chiari, the other way of looking at it is that Arnold-Chiari malformations have a likelihood of producing symptomatic dysfunction in parts of the neuraxis inferior or caudal to the dominant problem. So when you see upper limb involvement, when you see an asymmetric involvement of the brainstem, which is restricted to the level of the fifth nerve and not higher, then it's possible that there may be a comorbid minor basilar invage. But these constellation of symptoms and signs, I would think, are very, very typical of Arnold-Chiari malformation. So let's see what Abhay has to tell us.
Yes, sir. So for localization, there is a lower brainstem, then cerebellum or its connections, and in the cervical cord. So I will take it as a central cord syndrome, but because the dissociated sensory loss is a very important for us for localization, because
Yes.
more likely the lesion will be either in the spinal cord or in the brainstem.
So I think Karthik was in agreement with you. He was saying he was talking about an intramedullary cord lesion or a cervical central cord lesion. Right. Yes, Abhay.
So, should I wait for differential diagnosis now or after examination, sir?
You're all set to do your differential diagnosis. Why don't you do the differential diagnosis once you examine the patient? That might be
Okay,
better, right? We should not
okay, sir. So
buy our horses when you're not fully crossed the stream.
So on examination, patient is conscious, oriented, pulse is 80 per minute, regular, blood pressure is normal, there is no orthostatic hypotension, there is no pallor, icterus, cyanosis, and lymphadenopathy. Skin is normal. On central nervous system examination, higher mental function is normal. On cranial nerve examination, first and second cranial nerve is normal. There is no Horner syndrome. Third, fourth, sixth cranial nerve is normal. There is no nystagmus. On fifth cranial nerve examination, there is a 50% decrease in pain and temperature sensations in all three divisions with preserved sensation in central perioral area and tip of nose, suggestive of the Balaklava pattern of sensory loss. However, the fine touch is normal, motor is normal, and jaw jerk is normal. 7, 8 cranial nerve is normal. And on the 9th and 10th cranial nerve, uvula is deviated to the right side and gag reflex is absent on stimulation of the left side of posterior pharynx. 11th cranial nerve examination is also left side is affected because the trapezius and sternocleidomastoid muscles are weak. On 12th cranial nerve examination, left side of tongue is weak and tongue is deviated to the left side slightly on protrusion, and also vesting is there on the left side of tongue. However, there are no fasciculations. Then on motor examination, on the left upper limb, there is a mild vesting of the thenar and hypothenar eminence. However, there are no fasciculations. Then tone is normal in the upper limbs, both left and right upper limbs and right lower limbs. However, tone is increased in the left lower limb. Then on the examination of power, the shoulder and elbow power is normal in both right and left limbs. Then in the wrist, flexor and extensors are weak on the left side with power of 4/5, and small muscles of the hand are weak on left side. Then in the lower limb, in the hip, the left-sided hip flexors are weak with power of 4/5. Then again, knee flexors are weak on the left side with power of 4/5. And ankle dorsiflexor is weak on the left side with power 4/5. Otherwise, right lower limb power is normal. Then on sensory examination, there is a 50% decrease in pain and temperature sensation on left side of body and with a sacral sparing. Then there is a 30% decrease in pain and temperature sensation in the right upper limb, chest and abdomen up to the umbilicus. Fine touch is normal. Joint position sensation and vibration is normal. Cortical sensation is normal and Romberg sign is negative. On deep tendon reflexes, in the upper limb on the left side, tricep hyporeflexia is there. Otherwise, biceps and supinator is normal. Then finger flexion reflex and Hoffman sign is negative, absent bilaterally. Then in the lower limbs, the knee and ankle hyperreflexia is there on the left side. In the left lower limb, there is a hyperreflexia. A superficial reflex examination, abdominal reflex is normal on right side and absent on the left side. And plantars are extensor on the left side, however flexor on the right side. On cerebellar examination, the speech is staccato type. There is no nystagmus. Nose finger is positive. Dysdiadochokinesia is positive.
Is this bilateral or is it unilateral?
It's a bilateral.
And is bilateral symmetric?
Yes, sir. Symmetric bilateral.
Symmetric.
Knee heel test is abnormal. Tandem gait is impaired. In on extrapyramidal examination, there is normal. There is no rest tremor, no rigidity, no bradykinesia, and gait is ataxic gait, suggestive of cerebellar involvement. However, there are no meningeal signs. Skull and spine examination is normal. There is no tenderness, no swelling, no external deformity, and other systemic examination is normal. And also neck length is apparently normal. So there is no short neck or long neck.
Why do you want to know that, Karthik? he made a specific mention of short neck, right?
To rule out CV junction anomaly. Hello.
Did he? You have any thoughts on that?
Sir, Klippel fill is associated with the short neck. So,
Right. So he's trying to tell you that other associated abnormalities at that local region of the craniovertebral junction, he's looking for surrogate evidences that they are present or absent. Right. That's why he's looking carefully at the orientation of the skull and the neck.
So should I continue with summary?
Yes, you can do a summary and then maybe.
So is a 29 years female with 3 months history of subacute onset progressive continuous headache with neck pain, with left fifth sensory Balaklava pattern weakness, with the left 9th, 10th, 11th, 12th cranial nerve paresis, and most probably it is a nuclear or infranuclear type, with the cerebellar vermis and bilateral hemisphere involvement or its connection involvement. Then there is a left upper limb weakness of lower motor neuron type, and there is a left lower limb weakness which is of upper motor neuron type, and with the suspended dissociated sensory weakness, with there is a also
function.
sacral sparing and
Sensory can't be weak, right?
Yes, sensory involvement, and with
Sensory
sacral
dysfunction.
dysesthesia, and without bowel and bladder involvement.
Joy, Rohit is very quiet, Joy.
Yes, Rohit.
Here, involvement of the multiple cranial nerves with
Right.
Balaklava pattern and cerebellar vermis and hemisphere.
What is this Balaklava pattern, Rohit?
Sir,
I've never heard of this. So, for people who have not heard of Balaklava, would you be able to tell us what is this Balaklava?
When the nucleus of the sensory nucleus of the trigeminal nerve is involved, we see this pattern, sir, onion peel or Balaklava pattern.
Spinal tract of trigeminal nucleus, the rostral part used to supply the perioral and around the nose area, and lateral part is supplied by the caudal area. So caudal part is involved. So
and the rostral part is spared.
Spared, sir.
Okay, that's good.
So
ये Balaklava क्या है? Why do they call it Balaklava? What is this?
Balaklava is helmet that used to wear in the during the time of war and all. The previously. Sir.
Yeah. How long ago?
But I don't know, sir. Actually.
So, do we have any historians amongst the panelists?
2,500, the Spartans.
But they didn't wear Balaklava helmets, right? The Spartans did have helmets which perhaps looked like that, but this name Balaklava came from the Battle of Balaklava, and the Battle of Balaklava was in the mid 1800s because they fought in Balaklava, which is in Crimea, in current day, I think perhaps where Sevastopol is. So it's a part of Ukraine now. And in that battle, because of the very severe, harsh winter conditions, soldiers used to wear what we call a monkey cap. So a balaclava cap is a cap where the eyes are exposed and the mouth is exposed to breathe. The rest of the face is completely covered to prevent frostbite in the extreme weather. This was fought in late winter at that time. So the balaclava name comes from there. And of course, anyone who treks in Ladakh will wear balaclava caps. And if you go there to the Chadar walking winter. Anyway, so you're right. That's what the balaclava is. And it's the rostral part that is spared. Therefore, the mouth is spared. And he very graphically showed that in the diagram. You saw the diagram there. It's shown where there is sparing around the peripheral region on the left side. Okay, let's get back to the next one. Yeah. Yeah, Rohit?
Sir, so involvement of the lower brainstem,
Right.
along with that of asymmetric weakness with left
Yeah.
upper and lower limbs, LMN and UMN. And also, if you take that central cord involvement is also involved. So one of the possibilities is Arnold Chiari malformation 1 with syringomyelia, a possibility of syrinx extending distally. So that's why we are seeing brainstem involvement uh, along with that of central cord syndrome also. So one of the differentials is that one of the possibilities.
One of the possibilities. When you say one of the possibilities, you are actually what you are hiding in your glove is that there are other possibilities. You want to tell me what your other possibilities are?
And
It's a bit difficult, isn't it?
yes,
Because of the asymmetry and because of the segmentalized involvement of the neuraxis with parts which are square. So when you have suppose this patient had headache and did not have the trigeminal sensory but had left sided 9th, 10th, 11th, 12th, right? Just headache, 9th, 10th, 11th, 12th palsy on the left side, and the rest of the neurological exam was normal. Would you worry about other things?
I would yes sir, extraxial tumors I would.
Yes. Yes. What kind of extraxial tumor you think presents with this kind of lower cranial nerve paresis, asymmetric predominantly with headache without involvement of the limbs? Good, you're doing well.
Yes. And
We'd worry about tumors like clival chordoma, isn't it?
Glomus jugular tumor can be there.
Yes. So glomus jugular tumors and clival chordomas can sometimes present with very asymmetric, indolent 9th, 10th, 11th, 12th, with or without nuchal pains because of associated invasion into the dura. But obviously, you will not have the trigeminal sensory signs. You will not see dissociated anesthesia involving the limbs, and the very graphic weakness that has been described with the lower motor neuron kind of upper limb weakness, and the spastic weakness in the left lower limbs, with an extensor plantar on the left. So all of these clearly tell you that there is a pathology which is dominantly making the cervical cord also dysfunctional with a central cord syndrome. So if you want to put everything together, then yes, your Arnold Chiari with syringomyelia would be your first possibility. Riddhi, you have any differential on this? Rohit said that.
Could it be meningioma, without sensory involvement in the headaches?
Yes, so one would think that if you have a atypically placed meningioma in the again it would have to involve the region of the clivus. It would be very difficult for a meningioma to produce the dissociated sensory involvement in limbs, including the face. That tells you that the trigeminal nucleus and the descending tract in the spinal cord of the trigeminal nucleus and is made dysfunctional. For that to occur from a extraxial tumor, compressive, would be very difficult. And you know that meningiomas don't produce syringomyelia.
Yes.
Right? Whereas we know that a craniovertebral anomaly, by virtue of its distinctive association, the company that it keeps, not uncommonly, almost in a 1/3, you will probably find syringomyelia. So we know that from our understanding of CV junctional anomalies. So if you put all the findings together into a basket, then yes, Rohit's pinning the blame on Arnold Chiari malformation probably be appropriate.
I mean, it's a short story. It's just 3 months.
Right.
It's 3 months, and the 9th, 10th, 11th, 12th are in sort of continuity.
Right.
So some kind of a tumor of the brain.
I was also thinking of that if I need to explain the asymmetric lower cranial neuritis, then one would worry about tumors like a clavus chordoma. It would be very difficult to explain
Secondary
the
steering.
limb involvement.
Brain.
Sorry, Satish, I think the connection went off.
Glioma of sorts.
Sir, I think sir is telling about the tumor with secondary serines.
I mean, a glioma that goes down in the cord and produces a syrinx. Because for limbs, it is either a syrinx or
Yes.
going down into the cord.
That's an option.
Secondary. Yeah.
That's an option. You can't say no to that.
Yeah.
So how do we, if we do find, how do we explain the 3-month story?
There are no skeletal markers.
Sorry? I think the connection is not very robust. So in between, we are losing audio input. Can you hear me?
Yes, sir.
I think we lost Dr. Khadirkar when sir was speaking.
Yes, sir.
So Satish, I still find it difficult to explain the 3-month history.
Correct. Also, there are no skeletal malformations to really take us to the CVJ. I suppose that one would keep a tumor option.
Yeah, one could
Or an
keep
awkward,
option.
or an awkward infection of sorts, because it's just 3 months. Yeah. Yeah, that's the only thing I wanted to say. Yeah.
Yes, Abhay.
Sir, localization. Should I go ahead, sir?
Yes, so I think Ravina is asking, sir, which tumors can commonly occur with this clinical presentation?
Should I go ahead with localization?
Yes, do that.
Okay, so localization here is the lower brainstem because of the involvement of the left 9th, 10th, and 11th, 12th cranial nerve, and more likely it should be an extra axial lesion because the long tract they are not involved except for the cerebellar involvement. Then in the cerebellum, the both bilateral hemisphere were missed or its connections can be affected. Then in the cervical cord, it is suggestive of the central cord syndrome because of the dissociated sensory loss. And again, it is like a cape with the suspended sensory loss is there, but the left side is more involved. So it can be because of the involvement of decussation of the spinothalamic tract, and also it can be because of the right spinothalamic tract involvement. Then there is a left lower limb UMN weakness. It can be because of left corticospinal tract involvement. Then the facial Balaklava pattern. It can be because of left spinal trigeminal nucleus and tract involvement. And left upper limb weakness, which is of lower motor neuron type. It can be because of left anterior horn cell, C7, C8, and T1 involvement.
So Abhay, you have said the lower brainstem left 9th, 10th, 11th, 12th is extraaxial lesion.
Yes, sir. Because
will you explain that to me? What are you trying to imply?
Yes, it is because long tract like if you want to take a 12th cranial nerve, it is very medially. So more likely it involves the medial lemniscus also and corticospinal tract also. So it is not involved. So it is more likely to be extramedullary or extraaxial lesion. And again, the all fold cranial nerve to involve, it should be a very large lesion in the medulla. So at least some long tract should be involved to say it is a intramedullary lesion. Because all this, yes, sir.
So you're implying that the absence of the very significant regionality of the lower cranial nerve dysfunction is likely to be a traction phenomenon and not due to syringobulbia that you think could accompany the suspected syringomyelia that is very clinically manifest. I agree that the cervical cord clinical signs one would attribute to syringomyelia. So do you think the cranial neuropathy is part of syringobulbia or you don't think so?
No, sir, less likely because no long tract in the medulla is affected. And
okay.
Yes.
And also, Joy sir,
No MLA.
Dr. Kadilkar is saying,
Joy sir, Rakesh here.
yeah.
I mean, had there been a intraaxial 9, 10th, 11th, 12th, the right lower limb pain temperature should have got affected. The crossed sensory. Here it's reversed. His left lower limb is basically affected, along with the chest and both upper limb. But the right lower limb is actually spared.
Yes.
Temperature. So explaining it by intraaxial lesion, 9, 10, 11, 12 will be a little bit difficult. It should have been a large lesion, as Abhay is saying. So probably it's extraaxial, maybe as you rightly said, maybe a traction or.
Yes, so we often forget that many a time, if you have an anomaly that is dysfunctional in its anatomical architecture, it will produce symptomatology distant from where the architecture is abnormal. For example, a tethered cord syndrome can give you very typical symptoms in the lower limbs with sphincter dysfunction, and one would think that there is clearly an abnormality intramedullary in the lower end of the cord. But structurally, the lower end of the cord looks normal. It's just the tethering of the cord from the traction that produces the dramatic sphincter dysfunction. So, yeah, by the same analogy, if there is a anatomical abnormality in the architecture here externally, and we are saying it's extraaxial, then we will have to attribute the lower brainstem segmental dysfunction of the cranial nerves to perhaps a traction-like phenomenon if it's not due to syringobulbia. So let's see, we'll probably learn more as Abhay unfolds the other cards in his deck.
Should I go ahead?
Yes, I think you should go ahead.
So possible differential diagnosis. Should I tell my differential diagnosis?
Well, the others said that. You heard Rohit talk about Sjogren syndrome because of the trigeminal sensory, and he talked about sarcoid because of the trigeminal sensory. You heard Riddhi asked about tumors, right? So tell us what you thought when you saw this patient.
More likely is a first was the craniovertebral junction anomalies because it has started with the unilateral headache without vomiting. So it can be because of the stretching of the dura at the foramen magnum.
Right.
So possibilities can be atlantoaxial dislocation, basilar invagination, then rheumatoid arthritis with Panus formation. Then possibilities the Arnold-Chiari malformation, specifically type 1 because there was no syringomyelia. With associated cervical syringomyelia, sorry, that was in type 2, there is a meningomyelocele. So yes. Meningomyelocele was not there.
Yes.
Associated cervical syringomyelia with syringobulbia can be the possibility. Then as sir has said rightly, that it can be a cervical cord intramedullary tumor is the again possibility, because ependymoma, glioma, lymphoma, metastasis, teratoma, meningioma, they can also cause the syrinx as the complication. So that can explain the manifestation.
So you know what now Dr. Khadilkar was telling us about. The important thing for us to consider would be that if there is an ependymoma in the upper cervical cord, and instead of progressing caudally, if it's progressing rostrally, then it could well produce this whole constellation of symptoms and signs. And because it's an ependymoma, it may be indolent yet symptomatic only in segmental parts. So one can't run away from that. So I think someone in the audience had asked the question that in the differential diagnosis, what kind of tumors? If you really ask me, yes, we know we have written about lymphoma metastases, but I would think an ependymoma, we can't say no to that despite the symptoms that exist. What do you think, Dr. Karikar?
I mean, I'm a little impressed by the 3 month story.
Right.
The rather prominent headache, the four cranial nerves on one side coming together, no craniovertebral junction anomalies in the skeleton. So I would probably put a spinal cord tumor above CV junction anomaly. Having said that, CVJ anomalies can also have tumors along with them.
Yes. And also to complete the list, but the less possibility is the vascular, like vertebral artery thrombosis, dissection, or AV malformation, or the cervical spondylosis because of the hyperextension injury, but there is no history of trauma in this patient.
You know, in our rural setup, this 3 month history has to be sometimes taken with a pinch of salt because people are so stoic to suffering that they may not notice suffering until it is intolerable. And that sometimes is an explanation for a short story. So if you know, sometimes the story is very short, and we are a little surprised by finding an abnormality which we know to be congenital. Then one of the explanations is that until it really becomes insufferable, they don't seek medical help, and they have a very seemingly short story. But indolent but minor symptoms have been present for a long period of time, and they have been just attributed to life.
Absolutely.
So Karthik, do you want to see any investigation from Abhay? Do you want to ask any baseline investigation that you'd like to do in order to understand your suspicions, corroborate them, or maybe refute them if the initial suspicion is incorrect? So what kind of investigation should one do once we've got these findings?
Sir, I would like to do MRI brain with sagittal sections, and also involving including MRI cervical spine also to localize the pathology. And basic investigations, since we are thinking of rheumatoid arthritis with the atlant-occipital joint involvement, I would like to do RF factor and anti-CCP antibodies also. So
No, I
my
understand that. I think this whole rheumatoid thing is very romantic and very alluring too, because it's a very nice differential to discuss when the examiner asks, because it makes us feel very, very well informed. But for rheumatoid arthritis to present isolated with a very regional manifestation at the CV junction, we know that the Panis formation and the rheumatoid arthritis involving the atlantoaxial joint, were it to occur, it is more likely to produce secondary atlantoaxial dislocation rather than the number of symptoms that this lady has. And one would anticipate that there should be some constitutional symptomatology in the other joints of the body, which we don't have. But yes, I think for the purposes of being balanced, we probably ask for those tests too. But I'd be surprised if the ESR came back or the CCP came back and not.
Sir, X-ray skull base with the cervical spine in flexion and extension.
Yes, you could do that to make sure that the atlantoaxial joint is not subluxating into the cord when the neck is flexed. That's what the X-rays will tell you, and the MRIs that you want will tell us what the structure is. Obviously, the structural delineation of the MRI is far better than what you would see on a plain X-ray. Having said that, we would not forget doing it, but most of us now would probably order an MRI as the first choice. Yeah, right.
Yeah. So should I go ahead with neuroimaging?
Yes, you can show us the imaging.
Okay, so this is the T2 weighted image of the brainstem and spinal cord. So it is showing the cerebral tonsillar herniation and compression of the medulla. And it is also showing the cervical serings, and it is a very long, extending from the C2 to almost T11. And this is T2 weighted images, axial section through the cervical cord. So first is from upper cervical cord, and second is from lower cervical cord, and it is showing the asymmetry of the syrinx cavity, as it is affecting the left part more than the right, and also it is extending in the anterolateral part on the left side.
Right.
Then in the thoracic cord, so it has become circular almost, and also the diameter has decreased. And these are the flare images of the brain. Axial
So,
image.
Karthik, you saw that syrinx in the thoracic cord. Karthik, are you with me?
Yes, sir.
Yeah. You saw that syrinx in the thoracic cord. So, do you think there's anything in this physical signs that were very graphically described by Abhay in those slides that are attributable to the syrinx?
Sacral sparing is there.
Uh-huh. Do you remember what he told us about the entire gamut of signs when he went through the signs? Do you remember that, Karthik? He told us something about the superficial reflexes too.
Yeah.
So did it raise any kind of excitement when you saw that those superficial reflexes were absent on the left side? I was quite intrigued when he said that.
So, involvement of the corticospinal tract.
So when he narrated the whole story, I was trying to think as to what's the explanation for those asymmetrically absent superficial reflexes when he examined the patient. And I think that might be coming from the syrinx in the dorsal cohort. It's asymmetric, it is extending down. You could probably explain the abdominal reflex absence. Okay, Abhay.
Yes, sir. And the flare images of the brain. So it is normal, sir. Also the pons and medulla flare images are normal. So it is not showing any syringobulbia.
Yes. So here again, we see the anatomy, and the question to ask is that clearly Abhay has very graphically shown us that the parenchyma of the pons and the brainstem are not affected. Yet at the same time, the patient clinically has a whole remarkable bunch of symptoms to which you would attribute to dysfunction in these parts of the neuraxis. And that's what I meant by saying that sometimes you see in anatomical abnormalities of the exoskeleton and its secondary effects on the neuraxis. You may see manifestations distal from the local abnormality. And those manifestations distal or rostral. Here it is rostral from the abnormalities here at the CV junction. But higher up, you are seeing a rostral anatomical dysfunction, and that could be from the traction and the effects of a mechanical um, uh, pressure on the neuraxis. And that's why I was trying to give you the example of a tethered cord, where it just someone almost is like pulling like a pulley. They're pulling the lower end of the corda, and that's giving you a whole lot of symptoms. Though there is no structural abnormality in the lower spinal cord. Dr. Khadilkar, would you agree with that?
Absolutely. I think that's what it seems to be on these scans. Absolutely. That's a great thought.
And sir,
Wondering whether this is a plain scan or a contrast scan.
So T2 weighted plain scan.
It's a T2 flare, yes. He's got a flare also. Even the flare is without contrast.
Have you given a contrast?
Yes, sir. But the slide
we have not given contrast here.
Not here, but
no, contrast has been used, no?
Yes, sir. Used. It was normal. Yes.
We have a good. Yeah.
Yes.
Sir, one point I was making.
Yeah, Rakesh.
Yeah.
To explain the facial sensory impairment, there is no syringobulbia.
Yes.
But the fibers of the most lateral part of the face will sometimes descend up to C1, C2 before they cross over to the other side.
Yes.
Probably they are getting caught in the uppermost part of the syrinx. Otherwise, it is very difficult to explain the facial sensory impairment.
The facial sensory is also quite graphic. If you see that picture that Abhay drew, it's very graphic. And in relationship to that, here, if one looks at the MRI in the brainstem, tegmentum of the brainstem looks fairly unaffected. Yeah, you could be right. I think that's a very good explanation for.
And sir, one more thing which patient very nicely said, that on the face of this diffuse pain and temperature lost,
she can feel clogged.
Yeah, she clearly mentions that the touch of my clothes are intact.
Is intact, yes.
Yeah.
Yes.
So
there is a dissociation there. There is no question about that.
Absolutely.
You know, from the time that I've been a student, I've always been petrified of being given a spinal cord case. If an examiner wants to fail you, I think one could get a spinal cord case, and if the examiner is hell-bent on failing a student, there's no way you can pass. Yeah. Because this is probably one of the most difficult anatomical, clinical, correlative exercises to do. Because there are so many variations, there are so many ill-explained dropped levels when you examine a patient. And it can be quite taxing, and it can be very tricky. So as a student, and even now, I prefer not to be very dogmatic about what statements we make, because many a time we think that anatomically the lesion is at a point X, and to our surprise we find that it's not quite there. It's somewhere either rostral or caudal to it.
Yeah. True, sir.
Okay, so what did you do next?
So the patient is operated, sir, by a neurosurgeon, and it is doing better, sir.
Right, Karthik, if this patient came to you and so he's sitting in your clinic, you have passed your exam, and the patient says, what should be done, sir? So what do you think the neurosurgeon colleague of yours is going to do when he sees these set of anatomical abnormalities on the MRI? What do you think he's going to do surgically?
Decompression surgery. I think it could be the anterior approach or to the posterior, but I think posterior is more suitable.
Why would you do an anterior approach? You can clearly see flexion extension. There's no distance change between the dents and the odontoid.
One can remove the odentate process.
Really? When there's no atlantoaxial dislocation? Why would you do that? If there's an atlantoaxial dislocation, I agree that could be a neurosurgical thought. But for something like this, what do you think surgeons normally do? You must have seen other patients, right?
Posterior decompression.
So the therapy of choice, from what I understand, is that most neurosurgeons would conservatively decompress the suboccipital region and take away the infringement of the misaligned occipital bone at the CV junction, and allow space for the uh, dangling and herniated tonsil of the cerebellum. It allows space to move away from the cord. Whatever little understanding I have, I think surgical interventions aimed at diverting the syrinx have not been very clinically useful. Let's ask Dr. Khadilkar. He must have seen much more than us.
Yeah, I entirely agree with this. I mean, here lifting the flap from behind will probably get the headaches down, give
Yes.
space for the tonsil. But whether it will do anything to the syrinx, I don't know.
Unlikely,
Also, we will
right?
have to see all the scans carefully. Is there a connection between the cervical syrinx and the dorsal syrinx, or they are independent?
No, sir, there is a continuous syringe, sir. It is.
Okay.
It is continuous, sir.
That is better. That is better for the patient, because there are some in whom the syrinx sort of loculates, and then it becomes more difficult. Benefit can be expected, mainly in the headaches, cerebellar signs. But about syrinx, I'm not sure what will happen. Some people improve, but it's a tricky disease.
It's a very tricky condition. I think many patients don't improve much, and most surgeons are averse to trying to fiddle with the diversion from the syrinx, especially in the cervical region.
Maybe could be one can remove the through the posterior fossa that traction will be removed on the syrinx and it will give symptomatic relief to the patient.
So that's the enigmatic thing. I mean, even as a student, when we read about anal Chiari malformations in our training days and read about the printed literature, in fact, I shared some literature also with Abhay yesterday. It's very funny because every neurosurgical um, uh, scholastic academic paper writes about theories of its formation. So it is, the verdict is not very clear as to why, what's the pathogenic mechanism. So Gardner has his own theory. Somebody else has their own theory about the reason why the syrinx develops. So there is a hydrodynamic theory where compression of this nature, indolent from early infancy and progressing to adulthood, like in this lady, ultimately produces a misaligned CSF flow pathway, and that misalignment results in localized flow abnormalities in regions of the cord, and it does that. But the explanations are not very robust, so we don't really know what to do with them. We know what it is, but making an attempt to analyze and find a solution is quite challenging.
Abhay,
Yes, sir.
what was the height neck ratio? Did you measure the height neck ratio?
Yes, sir. It was 6.2.
6.2. Okay.
It was a spine to neck ratio, sir.
Spine to neck ratio, no? Yes. Dr. Krishnamurthy is there. He's a professor of neurology. Was asking that. Okay.
By 6.2, just explain to me what did you measure and what were the actual measurements?
Actually, for yes, sir. It should be neck should be in a neutral position. Then from external occipital protuberance to the C7. So that is this is the neck length, and spine length is from external occipital protuberance to the coccyx. Or just ask the patient to sit on the stool, and up to the last point of the stool, we can take it as a spine length.
So spine length divided by the neck length was 6.2.
Yes.
Yeah.
So what is the ratio that you are looking for as a cutoff to diagnose the short neck?
Sir, around 4 to 6, it's considered as means short. Long, sorry, sir. Spine to neck.
No, actually 6 I would consider is a little towards shorter side. Huh?
13.
When we were doing the Hirayama study and we were looking for the longer length necks.
Hmm.
The longer necks, the ratio was somewhere between 4 to 4.8 or 5.
Yes.
6 is getting a little shorter, 6.2. How old is he?
29 year.
29.
Fully grown. Yeah.
Female, and so
Okay. Okay. Yeah. Fine.
yes.
So was anything else done, Abhay, in terms of investigations for this lady?
No, sir, she was operated by neurosurgeons. The cervical laminectomy also they have done, sir, and suboccipital cranectomy they have done. And she is better, sir, after operation.
So what kind of cervical laminectomy? I mean, how long? I mean, all segments?
No, sir, actually exact I have not seen, sir.
Right. So you don't know the surgical notes?
Yes, sir, just I have asked the residents.
Right. Okay. So it would be difficult to imagine nuchal laminectomy. I think they must have done the upper cervical first, C1 to C3 maybe, to give enough space to that region. But I think this is a very difficult area, and the verdict is not out yet as to what to do with them.
Also, I think it will be nice if the neurology department keeps following this patient up. Because
Yes, sir.
then only you really know how much he or she improves.
Yes.
Surgical notes often are doing well, doing well, doing well. Yeah.
And the syringomyelia is a very enigmatic condition. And I'm reminded of a patient I saw as a student when with Professor Vadia when we were on one of the difficult patients got admitted with spastic paraparesis and asymmetric sensory dysfunction in the lower limbs and with sphincter dysfunction. And the very peculiar story emerged that this person was a higher level uh, criminal of some kind in Madhya Pradesh, and he was stabbed by by a person from the opposite gang, and the knife was plunged into his back and in the mid dorsal region, and it broke off and it produced a local injury in the underlying spinous process where he was stabbed. It was very close to the midline, and he received surgical treatment for the injury, and about 7 to 8 years later developed indolent progressive paraparesis. And when he came in with the paraparesis, the asymmetric sensory dissociated loss and sphincter dysfunction, it looked the clinical findings were very atypical and seemingly bizarre. But he had an isolated thoracic dorsal cord syringomyelia. There was no syringomyelia in the cervical cord. It was all in the dorsal cord from mid dorsal to lower down, and it was very unusual. And I couldn't find literature on it, and finally I had to trace traumatic uh, dorsal cord syringomyelia in Winken and Bruin. So there was one volume of Winken and Bruin which is there in Just Library, and that talked about trauma-associated dorsal cord syringomyelia. So apparently, syringomyelia in the dorsal cord were very common in the First and the Second World Wars, when many a time bullet injuries to the spine and when soldiers were blown off by an explosion in the trenches at wartime, blunt injuries to the spine resulted in dorsal cord syringomyelia. Perhaps because we don't work in conflict zones, we don't see thoracic syringomyelia. Most of the syringomyelia we see are cervical cord, and the only it, rare thoracic ones we will see are those where the syringomyelia is associated with a spinal tumor as a part of an intramedullary tumor.
Great. That's very, very interesting. Yeah. So we are a little over 10 o'clock. So if there are no other questions, shall we close the
Yes, I think
session?
we should close it. I think Abhay was very good
Any
and
other
the students were very good.
Yeah. Thank you very much, Joy. I think you discussed extremely well. Abhay, your presentation was very nice, and I think Karthik, Reddy, and Rohit participated very well. We'd like to thank everyone. And before we close, Rakesh, you want to tell the next week's thing?
Next week,
Rakesh, next week, what is coming up?
so probably we'll be taking histopathology of muscle, but yet to finalize it.
I think I must
Or
say
you
this is
will
a
declare later on?
superb
think
platform. I think this is
sorry.
a very
Yeah.
good initiative.
Yeah.
I think this is superb to do a bedside clinic with a presentation.
The second part of the
Next time we have two things. One is a spinal cord quiz, which will be followed by nerve conduction for exam going students.
Very good. Great. Thank you for having me here. I quite enjoyed being here. Thank you very much.
Thanks, sir. Thanks, Joy, sir.
Thanks for coming.
Thank you.
Thank you, sir.
Thank you. Thank you very much. Good night.
Good night.
Thank
Good
you.
night, sir.
Thank you.
Right, sir. It was nice case, Abhay.
Oh, thank you, sir.
It was nice. Really enjoyed. Nice. Thank
Thank you,
you.
sir.